thank you everyone for joining this event. We have a live audience here in Tentoul and people from around the world joining us on Zoom. In particular, our wonderful panelists joining us in a hybrid way today. So I am a senior lecturer and in the Stanford School of Public Policy, and I am also an affiliate to the Duke Global Health Institute, and I have the privilege of serving as the faculty director for the Duke UNC Rotary Peace Center. So I am very happy to have a panel where we are asking about human rights, health, and conflict, counting civilian harm. So we will have time for Q&A following the panelists' presentation, and we welcome questions from our in-person and our online audiences. People who are here with us, please hold your questions until we get to the Q&A portion of the event, and we have set aside a lot of time at the end for that. And everyone online, you're welcome to put in any of your questions. We are monitoring your questions, and we'll get to as many of them as we can. We'll try to make sure that you're included, even though you're in the cyber world. I want to make sure everybody knows that today's session is going to be recorded and posted publicly. Right. So I'd like to begin by noting that we conceived of this panel over a year ago. And our aim then was to consider the challenges for health and human rights in a conflict setting. The current war in Israel, Palestine, and Gaza is not something we had been able to study, and we will get to it, we will touch on it to the degree that we can with humility and respect. As you know from the website, the panel's guiding question is, what does it mean to count the harms caused by war and conflict? The panel will explore this challenge, of accurately quantifying the harms of conflict from an epidemiological perspective, as well as ongoing work to improve upon international humanitarian law, which is called International Humanitarian Law, IHL, the role of this in minimizing a broad set of harms that are deeply affecting civilians. And that would be from a law and policy perspective. In short, the question that we are asking ourselves as experts and everyone here with us is, how might better counting help make civilian harm count? So I will now turn to the first part of our expert panel, which will be that these experts, first in the cyber world, my colleague, Dr. Reverberating Guha-Sapir, who will begin, and I'm going to give a little bit of an introduction about each of our panelists right before they begin, but of course, you will be able to read much more. They have very deep bios on the website, so please do consult that as well. So Dr. Guha-Sapir, welcome. You are an epidemiologist specializing in humanitarian settings, including natural disasters and civil conflicts. You've been the director of the Center for Research on Epidemiology of Disasters for over 30 years. You hold a PhD in epidemiology and preventive medicine from Université Catholique de Louvain, and you've been awarded so many awards, including the Sapphire Award for Services and also the Blue Planet Prize for your contribution to environmental and climate research. Thank you for joining us today. And I welcome you to offer your thoughts to begin, and then we'll turn to Dr. Repkin.
Thank you, Edme. Thank you for inviting me to this panel. I'm not only pleased, I think I'm honored to have, the students of your university and maybe, others as well. And I'm looking forward to hearing what questions are raised during this event. It interests me a great deal to see what the younger generations are actually thinking about this now. When I started my career, I started my epidemiology studies at Johns Hopkins in Baltimore, and then I left. I did an internship, and that has some relevance. I did an internship at the Baltimore Sun one summer, and this was a very leading experience for me. It was a very short internship. It was 3 months. It was a very revealing time that I had there, because I remember one editorial meeting where I was allowed to sit in, where all the important people in the different sections were sitting to decide what goes into the newspaper next day. And the editor at one point, he heard all of them, and then he said, blood leads. Blood leads. And that stuck in my head. I was quite young at that time, and I'd just come from India. So, from a very kind of a naive background, and blood leads. And that was quite a striking thing. I thought about it for a long time afterwards. Deaths focus the mind. Death focus the minds. And that is why death tolls are important. In one way, you would say, from an epidemiological, very, how would I say, very pragmatic point of view, people who are dead are less of a problem for us, right? Why is it? Because our concern is with the public health of the living. The people who are living are a problem. People who are dead, in a sense, sad as it is, they are dead. So what is the point of this death tolls? All this years that I've spent, and me and some of my excellent colleagues, I mean, there are some brilliant experts in this very narrow field, niche field. Why do we fight, tooth and nail to estimate death tolls, a number of people who've died? Why do we do it? Well, if this audience may remember, well, some of them may remember, depending on how old they are, Hurricane Maria in Puerto Rico, not so long ago, some years ago, but not so long ago. Hurricane Maria. Hurricane Maria death tolls ranged from, I think, 46 or 64, I'm getting dyslexic, 46 or 64, that the US government leader at that time declared as the number of people who have died at the Hurricane Maria. After that, there was an estimation of excess deaths, and I'll go briefly into it later on. The estimation of excess deaths, it's now very commonly used. It's used for COVID-19, it was used for the heat waves and so on and so forth, estimated there. And I think the number there was 4,000 something. So first we had 46 from the head of state of the United States. And then we had 4,000 something excess deaths. And then we had an academic study that did what we call a body count. And they came up with 3,000 something. I can't remember exactly what. You can look it up. It's there somewhere. Anyway, so what does this mean? It means that death tolls, in fact, have three main objectives. Why do we calculate death tolls? They have three main objectives. The first one, and the most important one, in my opinion, and that's where IHL comes in actually very largely into the scene, is accountability. Accountability. People don't die in vain. People don't die in vain. And if we don't have some kind of accounting of how many people died, who and where, we are essentially saying that we don't really care. We don't really care that all these people died in El Fasher in Darfur. El Fasher, Darfur, what does it matter? A few thousand died, bien, that's it. So one is accountability. We must, it's a moral imperative, but it's more than that. So we have accountability. This accountability and death tolls are directly related to the credibility of the source. And why is that? And that is because of the politics of death toll. And we will, I'm sure, discuss it in much greater detail later on in this panel. The politics of death toll is absolutely critical. And that is why accountability and credibility of the source is so important. Either the death tolls are too high, because there is an interest of a party putting out these numbers to have very high deaths, because they want to get attention, international attention, humanitarian aid, whatever, or it's very low, like the Hurricane Maria. very low. And why is that? And this has happened in the Philippines as well. It happens quite a lot, actually. Very low because the government doesn't want to be fingered for not having responded. So they don't want to say that, thousands and thousands of people have died, because then somebody will say, why did the government do anything? The second big reason for getting death tolls, Adme, do make me a sign when I'm nearing the end of my time, and I'll just wrap up very, very quickly. So the second reason for death tolls is advocacy. That is the most common reason. You see, because we all want the frontline attention. We want to say, thousands of people have died, and, there's all in terrible state, and, we want more money, we want more attention, and so on and so forth. Advocacy. And that has been typically the use of death tolls. So accountability, advocacy. And the third reason why we make death tolls, we estimate death tolls, we don't make them up, I hope. We estimate death tolls is programming. We need to program resources. We need to respond to people's needs. We need to understand who is dying where. Are they dying of violence or are they dying of disease? The two have completely different responses. So essentially, those are the three main reasons why we kill ourselves over, literally, maybe, over estimating death tolls. And I end here and look forward to the discussion and Mara's presentation.
Thank you so much for that three-part analysis so quickly, and well done. Thank you. I'm going to turn now to my friend and colleague who's here in person, so we don't have this feeling of across the world, and say welcome to you, Dr. Revkin. As you know, you are an associate professor at the Duke Law School, and your research has been in the area of armed conflict, peace building, and transitional justice. And you have a regional focus on the Middle East, particularly Iraq and Syria. So in addition to Dr. Revkin's academic research, she has worked with a number of United Nations agencies and humanitarian organizations, designing evidence-based programs and policies. So your aim has been to strengthen the rule of law and the protection of human rights, to support peaceful reconciliation after conflict, and to mitigate the root causes of political violence and extremism. So I wonder if you can give us 8 minutes.
Thank you so much. It's really a pleasure and an honor to be on this panel at this particularly important time, I think, for thinking about how we measure civilian harm. I also want to say thank you so much to the Global Health Institute for inviting me. Just 3 observations building on Dr. Guha-Sapir's earlier points, based on some of the research I've done in Iraq, Syria, as well as South Sudan. I just returned from South Sudan a few days ago. So some of the big themes and problems in this work from a political science perspective. A big part of my research agenda has been about arguing that scholars and policymakers have been systematically underestimating the true costs of war, because traditionally the field of political science, as well as journalism, as my colleague mentioned, have focused on measuring harm through death and mortality as the most obvious and invisible indicator of death. Of harm. We've seen this in the field of political science, where even thresholds for defining what counts as armed conflict are based on numbers of fatalities. So major data sets set the threshold at 1,000 battle deaths per year. Over time, we, myself and other political scientists, have increasingly recognized that we are missing an enormous amount of harm by focusing primarily on deaths or lethal violence. And it's leading to incomplete and biased estimates of the true harms of war, because we're not considering all of these other enormous impacts of war on civilians, including forced displacement, including sexual violence, PTSD, many other forms of violence, and human rights violations that are more difficult to observe. So just one example of this, I did field research in Mosul for my dissertation shortly after the city was recaptured from the Islamic State in 2018. And I was visiting schools, interviewing teachers about their experience trying to sort of restart education after the conflict. And most of the schoolyards, playgrounds outside of schools, had informal graveyards, which are bodies buried around the playgrounds, because there simply weren't enough sort of formal burial grounds to put bodies into during the war, and so they ended up in school playgrounds and anywhere else people could find space. So and these children were back to school and sort of playing amongst these horrible visible reminders of war. And I think this is one example of how persistent the legacies of armed conflict are. And so despite all that these children had been through, 3 years living under the Islamic State's brutal authoritarian rule in Mosul, or displacement to nearby camps for IDPs, they sort of then had to sort of try to return to school and still be surrounded by persistent reminders of everything they've experienced. And that's an example. Impacts on education and child development are an example of one type of harm that's largely ignored by the social sciences. So together with my Duke colleagues, Ben Crick and John Petkin, we are working on a study that triangulates between a lot of different types of data, satellite data that detects visible damage to property structures, as well as individual household survey data with self-reported information about harms experienced by household members, and then in-depth interviews to sort of reconstruct a fuller picture of harm. And this gets to it. I just want to note here that part of why we have historically underestimated why sort of civilian harm is such a problem in contemporary conflict has to do with the fact that conventional proportionality analysis, which is a key framework within international humanitarian law, has a very limited sort of cost-benefit approach to calculating what is an appropriate level of civilian harm in comparison with anticipated military benefits. So the formula requires that militaries estimate sort of the anticipated military advantage of a specific attack on a specific building or target in comparison with the anticipated harm to civilians, looking at a fairly narrow radius of anticipated civilian harms, maybe within that same building or nearby, but not considering any of these knock-on consequences for healthcare, education, or just the long-term psychological effects of exposure to protracted conflict. So I'm working with a team of researchers at Oxford, Georgetown, and Essex to study this problem of what we're calling cumulative harm, which refers to not just the immediate damage caused by an airstrike, but all of the follow-on knock-on consequences that contribute to then make it very difficult for civilians to recover after war if they are even lucky enough to survive. A related, it's 2 more minutes, so I just will stop. So I'm going to just comment on my last line of research and teaching, and I talk about this a lot in my class on transitional justice here. But a major problem in the field of transitional justice is what we call competitive victimhood. And this is where different groups of victims, sometimes on the same side of the conflict, often on opposite sides of the conflict, are faced with this zero-sum world of limited time and resources and limited attention spans of the media, where there is only so much sort of assistance and empathy to go around, or at least that's how it feels. And so different groups of victims will then compete sort of over who has suffered more. And this relates to Dr. Buha and Deborati's comments about death tolls, because we end up in situations where counting of civilian casualties is really weaponized as a tool to try to one-up or sort of score points against the other side. And we're losing sight of the fact that as civilians on all sides of the conflict have suffered enormously, and this sort of inability to recognize other parties as victims is a huge barrier. It often goes hand in hand with mutual dehumanization, and is something that I think is a major area for research. How do we actually make it possible for different groups of victims on opposite sides of the conflict to be able to recognize each other and empathize with one another? I'll stop there.
Thank you. Thank you very much. That's sounding our human rights note for us. So the format at this point now is for us to have a little bit of a conversation as a panel. And so I'll start with a question each for our panelists. So Dr. Buha, I love the way you began with how there's a kind of a political economy to the approach to death. and that it sells. And I'm wondering if that problem of the political economy attaches to journalism, where they have to think about how do you get eyeballs on your material, how that enters into academia. Like, how does it work that you have this very niche area that you have to struggle? I mean, you ended your remarks saying we struggle to be able to do this counting. Like, how do you overcome the larger forces of advocacy around you to make sure that you do honor these deaths? What are the kinds of struggles you've had or triumphs you've had in this regard?
Yes, well, you know, we come with an advantage. We come with an advantage. And the advantage is that academia itself has a certain amount of objectivity that comes with it. You know, I'm not saying they do, in fact, all the time. In fact, they don't. I'll give you an example of that. But it comes with that little advantage. Academia, this is an academic, this is a scientist, and therefore he or she can be expected to be objective. So that's something that we have in our baggage. The struggle was mostly in the beginning. I mean, we started very early with Darfur, with estimating deaths in Darfur. Why? Because we found that our little team, you know, we are a very small team. Our little team found that there were these numbers that were floating around Darfur genocide of, you know, 500,000 people, 1 million people, you know, mowed down and so on and so forth. So all these numbers were running around, and we just simply thought we had no big background in the business. So we just thought that let's try and use epidemiological methods, you know, results from sample surveys and modeling, Bayesian models, and come out with a number. And we came out with a number that was substantially lower than the numbers that were thrown around for Darfur. This brought us incredible amount of pushback. I mean, incredible amount of pushback from the newspapers, even from our colleagues in the US. And why did we get so much pushback from our colleagues in the US? Because at that time, Darfur was a rallying cry for the government that was in place. At that time, it was Mr. Bush. And there was a rallying cry from, if you like, the left, who wanted to have, you know, the action taken on Darfur by the US government, which the US government was not doing. So that kind of thing, what happened, I had colleagues call me up on the phone and say, whose side are you on, Debbie? Are you on Mr. Bush's side? And I just thought, I may be. Why not? If what my results show that, you know, Mr. Bush is right, well, Mr. Bush is right. So academia, in a sense, has that independence and the credibility. And that's a very important thing to hang on to not be buffeted around by journalists, however important, calling you and saying that, do you want to redo your calculations a bit? So yeah, that's how we had to deal with politics. And after a while, we got some, you know, a reputation, and that is worth its money in gold. You know, you have a reputation, you come out with a number, people take you seriously.
Thank you very much. All right, Dr. Revkin, I wonder, as a fellow policy analyst, if you could expand a little bit more on the principle of cost-benefit analysis, which lawyers know is the basis for so much of regulation in our country. It's actually required to do cost-benefit analysis for many policy. It's also very much part of policy analysis. So I think this is something very important just to learn about the law here, what cost-benefit analysis misses, but how that same concept of cost-benefit analysis can be used to do some correction in the way we think. So I wonder if you could speak a little bit about the study that you hope to do, where you're hoping to capture much more accurately and with much more, trying to think of the right word, the kind of texture we need to understand, down to the children who are playing, whose developments are harmed in invisible ways. And that's the big issue for someone who's an evidence-based social scientist. What do you do when you're trying to indicate the harms with the texture that's needed for invisible harm?
Yeah, so this is the question, and I say I'm limited in how much I can say about the upcoming study because it's still in progress. We don't have findings yet. But this is a project that builds on the work I've previously done on measuring civilian harm in Mosul, Iraq, and we have planned to work on a comparative study. Looking at both Iraq as well as Israel and Palestine, looking at different measures of harm, taking an interdisciplinary approach. And that second part of the study is very much on hold right now. But I will say that going back to sort of the legal frameworks, I think an important thing to understand about the current state of international humanitarian law is that the principle of proportionality was developed at a time after World War II, when we had a really different kind of warfare, that primarily ground wars to some extent with air support, but not nearly the level of airstrikes or drone support that we see today. And so we were dealing with a different type of war in which most of the people being killed by war were combatants, or at least all of these casualty counts are incredibly contested, and we don't have objective measures, but we know that at least historically, these wars were more costly for combatants than civilians. That has changed with the rise of air wars, particularly after the US wars in Iraq and Afghanistan, when backlash against US casualties and concern over sort of protection or aversion to casualties among US troops pushed sort of the US and other major military powers to shift so many operations to the air. And so I think that is where we see that, and as a result of that, we don't have exact reliable data on the proportion of civilians to combatants being killed in contemporary wars, but we know it's much higher. That sort of far more than half of all people being killed in wars today are civilians. So, so this just suggests that there is a mismatch between sort of the framework that has been governing our armed conflict since World War II, that was designed for a very different kind of war, and the types of conflicts that we're now engaged in. And so part of our effort is going to be, and it's very, very difficult to change or recommend new interpretations of very foundational frameworks. But I think what we're trying to argue is that both changes in the technology around war changes in the actual sort of nature of warfare necessitate that we update the way that we think about proportionality.
Okay. Well, now we're going to have a little bit of a conversation amongst the panelists. So I invite you, Mara, to go next.
Deborah, it's really such a pleasure to be in conversation with you. And I'll also just say, I think we share an interest in journalism because I interned for some newspapers as well until Career Services told me that there were going to be no jobs there. So, but anyway, Coach, I thought deeply also about the journalistics, sort of how our work is different from the work of journalists. So I talked a little bit about the development of my field in political science and how our approach to measuring non-lethal harm has changed. And I wonder if you could say a bit more about sort of how you see your field having changed over time, and what is sort of the leading edge, or what do you think are the most promising methods out there for estimating sort of a broader range of harm beyond just death?
Yeah, it's come a long way. You know, I'm sounding like, I don't know who remembers, there used to be an advertisement from cigarettes, for those who remember cigarettes, of Virginia Slims. I don't know, and there was, you've come a long way, baby, and you had this woman, remember?
Oh, yes.
And that applies to epidemiology of conflicts and disasters. It's come a long way. It started in Biafra. That's when it started. It started with the MSF guys and the ICRC people who, 3 doctors who left and formed MSF. And at that time, that's when the whole thing started. That's the whole the concept of epidemiology applied to conflict situations started with Biafra. And it was a remarkable story. It's a remarkable story. I'm not going to go through that, but it went through the next big milestone watershed was the famines of 1984-85, the terrible, terrible famines in sub-Saharan Africa, and then the famines again, after which many heads rolled. WHO, the head of the emergency department, was sacked, and many people were fired. Now, what has happened is that somehow epidemiology and data became much more important, I would say about 10 to 15 years ago. 10 to 15 years ago, the policy started getting much more evidence-based. So the overseas humanitarian aid offices, such as DFID, it was called DFID at that time, or the Office for the Coordination of Humanitarian Aid of the United Nations, all of those guys were actually started having much more of they were being inspected much closely after the famines. The famines were a terrible thing. And they were inspected, and they started to need data to be able to prove their point. And that's when all of this started, this rapid malnutrition estimations. This was famine, but not only conflict related. How do you estimate very quickly how malnourished the children are, so that how urgent is the aid? Death tolls started, disease outbreaks, all of this started coming in. And so I would say today, most of the large public health schools in the Western world, in UK and in the US, have a program on humanitarian aid. And that is largely, not only at all, but largely epidemiology based. And so, yes, today I think there is a lot of consensus around methods. There are very good methods. There are the body counts, which are very hard. They're mortuary driven. You get body by body by body. Your field knows it very well. This is how the International Criminal Court and the Court of Justice works. These are body counts. They are sample surveys. We do sample surveys. There are methodologies now developed, very good methodologies. There is excess mortality. How many people died at the same time before the war and how many people are dying now, and what is the difference? And then there is, of course, modeling, just plain old Bayesian models, or, those regression models, all of these models. So the methods have evolved. There's still blood on the floor on which method is better than the other method, but that will always stay, and that's fine.
So, Dr. Guhasapir, I invite you to ask the question that we discussed about for Mara.
Right. Yes. Mara, we, very, very early on in my career, I was in Somalia. This was some years ago when it was Mohammed, what was his name? Start confusing all the Al-Fayed. No. Anyway, whoever it was in Somalia, I was there in the middle of the war, and I was there in the same house. I was sleeping in the same house with the Save the Children and with ICRC. And I had the good fortune to have breakfast and lunches with one of the ICRC lawyers. There was a whole group of them there, but one of them, a senior man called Paul Bouvier, and we had, and at that time, I was much younger, and at that time, I couldn't figure out, given what I was seeing in Somalia, I couldn't figure out what IHL was actually bringing. What was it? You had all these lawyers, top-class Swiss Geneva lawyers and things like that. And I just thought, what are they possibly bringing to this chaos and to this butchery? And I would like, after so many years, I would like you to give me some insights as to how you see IHL actually beneficial to the victims of these wars.
This is a fantastic question. So based on my experience what I've seen in Iraq and Syria, I would say that I think in trying to offer something at all optimistic about the promise of IHL in our current times. So I think we have seen examples where IHL, so IHL really only works if it as a system of norms that's internalized by different parties to the conflict. So states as well as non-state actors, which are also bound by IHL. And in that sense, it is a on the front end, sort of a faster, more efficient way of. So you can't. There's a lot of talk about accountability for war crimes right now that will eventually require very drawn out, labor-intensive, evidence-intensive processes that won't be able to start until hostilities have actually ended. And in the meantime, IHL is sort of the best and only tool that we have, I think, to be used to whether it's to shame or parties into better complying with laws of war. It is unfortunately, I think, a tool that is about sort of mitigating harm in a situation where ideally we would not have war in the first place. I guess I think of this in the context of Syria, where Geneva Call, an organization that does a lot of engagement with non-state armed groups, was able to negotiate what they've called deeds of commitment with different Syrian rebel groups, getting these armed groups to agree to not recruit children under the age of 16, and in some cases younger than that. So, and that was an example where, as awful as war is, these norms and their internalization, even by non-state armed groups that are not recognized by the UN, was able to at least limit the exposure of civilians, or limit. It meant that sort of fewer children were at least involved in armed conflict. But yeah, nonetheless, I mean, I remain very pessimistic, I think, about the ability of IHL really only works to the extent that, yeah, it is internalized and the parties that are engaged in war are susceptible to shaming. But I do think nonetheless it's a powerful tool. I mean, there are legal frameworks. The United States is providing weapons to various parties, and I'm providing weapons to Israel and in conflicts around the world. And we have domestic laws and policies that require that we not provide weapons to countries that engage in, military state that are engaged in war crimes or human rights violations. So I do think that there are levers there, and as flawed as it is sort of the best and only available tool. And I do think there are some, we have seen some evidence, at least, of success in some cases.
I love the question. Thank you very much. So this is going to be the last question I'll ask for both our panelists, and then we'll fall to our participants here to participate and engage with us. So get ready, okay? Right. So I'm going to drop this doctor stuff because we've been talking to each other, Debbie and Mara, all these months of preparing. I'm going to say, Debbie and Mara, with your respective disciplinary hats on, how have you been thinking about counting the civilian harms bound up in the Israel-Palestine-Gaza war? Debbie, if I can ask you to go first.
Yeah, I mean, I can go first because I'm going to be really quick. I'm not a specialist of the Israel-Gaza conflict at all. Admit, I have to, confess right on top. So it's very hard. It's an extremely complex situation, and you need, long expertise to understand a little bit how things are going. From a purely epidemiological mortality point of view, there are methods such as what we call capture-recapture methods. So, you capture on one side and then you capture again on the other side and see how many of them coincide. But in any case, I mean, just for the final statement here, this is not a time right now in which one can, dance in and say, we are doing epidemiological studies on mortality. It is in full evolution, and I just don't think it's appropriate to even discuss these kinds of things when things are actually happening on the ground every hour. So I just claim ignorance on this and pass it over to Mara, who knows more about this than I do.
A few thoughts. So although I do have no more, I follow the conflict very closely. It's close to my work, but I feel that, as you said, out of respect for the seriousness of the situation, I wish that we had the time to give this a full conversation with as much depth as it deserves. That said, I'll just make a few observations that I think speak to our broader conversation. We talked first sort of about different types of bias in how we count casualties, and in political science we refer to something called a violence bias, where sort of social scientists and the media tend to look sort of wherever the violence is flaring up most, which right now is Israel, Palestine, and Gaza, and that ultimately is. I very much have this conflict on my mind, but I have all of the ongoing conflicts I work on my mind, as well as so conflicts in Ukraine and Sudan. And I think for those of us doing the work of sort of long-term social science, I think it's important. I think it's important that we continue to sort of work on cases broadly. But that said, an incredibly important and disturbing crisis that we have here. And I want to say just a word about this through the lens of competitive victimhood, which I mentioned earlier, but I think it's a really necessary starting point for any thoughtful conversation about this conflict, is to recognize that both sides perceive themselves to be victims of genocide. For Israelis, that's the Holocaust. For Palestinians, it's the Nakba. And we can, without sort of debating the relative magnitude of these atrocities, we have to be able to agree that both sides legitimately perceive themselves as victims. Otherwise, there's no way to have a conversation that is mutually humanizing. So I think that is the starting point that I take. And I think what follows from that is, as Deborah, you mentioned, I think it is a really difficult and toxic time in which to be trying to collect evidence and information. We are seeing some of the highest levels of historically unprecedented high levels of disinformation. Actors on both sides fabricating data to sort of try to, what I talked about before, outbid or sort of, compete against the other side. And I think it's ultimately very harmful for all of these civilians on the ground. And amidst sort of all of the noise on social media, I think it's just really important to return to a focus on the civilians actually affected and what kinds of discourses are most helpful to them at this time. And I think one thing is to actually listen to Israelis and Palestinians whose voices have been often sort of crowded out by all of the other information and discourse that we're seeing. And then also, I think in terms of, this is where IHL is sort of the most important tool for preventing further harm. And so calling on different parties to the conflict to comply with their international legal obligations. And I think some of the conversations that we're having about war crimes, there will be time for those conversations later on. But yeah, for now, I would just encourage everyone to sort of consider this framing of mutual recognition of victimhood as an important starting point for talking about this.
Yeah. So I guess what's so many things to say about that from a legal perspective. One thing to know is that there's sort of two bodies of law here. One is this international humanitarian law, also called law of war, and the other is criminal law. And so we're in the ex ante phase, right? What happens before the end of the war when it's possible to hold people accountable directly. And then that ex ante phase, we rely on this international humanitarian law. We really rely on the frameworks that we as policymakers, social scientists can develop and say, these are the ones that we should use to analyze things legally. And then after the conflict, then we go to the criminal law. So none of us are able to talk about that second body of law, at least for today. So with that note, can I see if there's anybody either online or right here who would like to enter into our conversation with us?
Well, maybe I'll start. So for those of you who don't know me, I'm Chris Beyer. I'm the director here of the Duke Global Health Institute. And I founded some years ago a Center for Public Health and Human Rights at Hopkins, where we did a lot of this work. And part of that center, part of our work was housing the Coalition on Safeguarding Healthcare in Conflict. And this is really the question I have for you, because I think if you think particularly about the longer term sort of collateral damage of conflict, one of the most lasting injuries is the destruction of healthcare and the deliberate attacks on healthcare providers. And that, of course, has been a prominent feature of the Syrian war, as I'm sure you know, and only got worse when the Russians came in with their air power and further attacked hospitals. And we spent years pushing to get WHO to begin to actually measure healthcare conflict and assess it. And you may know that the first conflict ever where they have agreed to do this, we got through the World Health Assembly and then eventually to WHO, is Ukraine. The Ukrainian conflict is the first one where WHO is actually engaged in the business of confirming attacks on healthcare. And that's very important on healthcare facilities, but also on healthcare providers. And I would just challenge a little bit all of your arguments that you can't really do this while it's happening, because it is being documented in Ukraine while the bombardment is underway. And WHO is confirming those attacks. And I think that's really important for understanding, the dynamics of that conflict, and also for the rebuilding that hopefully is on its way. So I guess the question I would have for you specifically is really around how much in your models and the cost effectiveness elements attacks on healthcare and violations of sort of medical neutrality are part of your debate, part of your discussion.
This is a great question. So first, I would just separate out. I would say I agree with you that definitely holding parties accountable for their obligations under IHL is possible. During one, you see that. I think we just need to sort of separate out these two types of accountability. One for IHL, and then the separate questions of criminal law, international criminal law accountability, which are coming up. There's been a lot of talk about what is and is not genocide, and that's sort of a separate set of issues that are bracketed off. But yes, in terms of IHL, we absolutely see that. So part of why, and I share your concern about the enormous is the shift that we've seen towards targeting healthcare and other facilities in contemporary conflicts, not just in Ukraine, but this has been a huge problem in Syria. It was also in Iraq, as well as Yemen. And one of the legal arguments underlying this that combatants are making is that these facilities constitute dual use objects that serve both military and civilian purposes, and often those are disingenuous arguments. They're saying that because the hospital, militaries, this is the case with the Syrian government, claiming that a hospital is being used actually for training purposes or to train military forces. And it's very difficult for outside, without journalists or human rights organizations on the ground. It's extremely difficult to verify those claims. So a challenge for our project, and I'll say too that this concept of dual use target has been invoked by the US. It's been really promoted by the United States. In the wars that we fought in Iraq and Afghanistan. It's being used by Russia and being used by China in their conflicts, but the concept really sort of originated largely with the US sort of lawyers. So I think a big thing we'll be pushing for is to try to roll back this concept of dual use and at least impose some kind of limiting principle, because literally anything can be dual use. I mean, this piece of paper could potentially, I could write something on this that is relevant for war and turn it into sort of being used for military purposes. So there has to be, and currently there's no limiting principle. So that's definitely something that we'll be working on.
Debbie, can you respond to our other question that Chris asked? And I think the crystallization from your perspective is, Chris is skeptical about how we can't count during war. And so, especially not being able to count the harms to health workers and to healthcare. I wonder if you could just clarify what you think it is that epidemiological methods can't count and what they can count.
Right. Well, actually, my comment was linked to death tolls.
Right.
So that is a moving target right now. It's literally a moving target from hour to hour, and it wouldn't make much sense to come out with what the death toll is today compared to the death toll tomorrow. So it was, but going to what Chris just said, and I think about attacks on health institutions. To me, it's, Syria, I think he raised the whole thing of Syria, and we did a very in-depth study on Ghouta, just outside of Damascus, on looking at, we did a spatial analysis of hospitals that were bombed, partially or fully destroyed. It's extremely difficult to do. It's extremely difficult to do because it's like even in earthquakes, destroyed or damaged are very subjective concepts, really. I mean, a few windows broken and things is not the same thing as all the operation theaters out of commission. So it's a very, very subjective thing to do. And that's not to say that it's not important. But as Mara said, and I think that's important to remember, is that today I think there is no real question on the illegality of targeting health institutions, and Mara will correct me if I'm wrong, I would say that today almost there is no question in the world that this is a wrong thing to do. When I was in Somalia, God knows when, a long time ago, I remember with the ICRC, I said I was with the ICRC. Then when there was some attack on ambulances, for instance, there was an ambush on an ambulance. This was an unthinkable thing. Nobody ever hit anything with a Red Cross on it. Nobody did. That opened the floodgates. But still today, I think attacks on health institutions is a war crime, or should be a war crime. I don't know, Mara, I don't know whether it is a war crime or not, but it's definitely not an acceptable. Now, what exactly one would need to have? Numbers of institutions that have been destroyed, or how they were destroyed, and what one could do about it. I mean, I would be very happy to have insights from Mara and from Chris or anybody else.
I think the point I was making is that until this resolution and until WHO adopted this approach, there was no formal mechanism by which to confirm these kinds of attacks. So just as you were saying that, this is sort of victim blaming on all sides and the argument of dual use, but also collateral damage. It wasn't intended, we didn't intend to do it. I think, like so many things, if you don't systematically count, you really can't say. And so the advance here is that WHO now has, as part of its mandate, collecting these data, confirming whether or not attacks on healthcare workers, ambulances, and so forth have happened. There's no question that this has always been a violation of medical neutrality. The difference is we didn't ever have a mechanism, a formal mechanism by which to count it. So that is a substantive change.
I'm going to move us on so we can get one more question at least. We're kind of at that point from online. Lisa, can you?
Well, we have a couple of questions, but just specifically, someone has asked, could you define dual use for the purposes of this discussion?
Yes.
Yeah, so dual use is a doctrine that the US military has embraced, in which IHL laws of war, one of the bedrock principles is distinction, requiring to distinguish between civilians and combatants and civilian objects and military objects. And the principle of dual use says that if a civilian object is used for military purposes, it becomes a legitimate target. And the problem is that there really is that's about as much of a definition as we have. And there's no limiting principle that says, well, if it's 95% civilian, but there's sort of, one combatant who maybe goes in there and buys some food, taken sort of the current sort of definition and lack of any limiting principles allows militaries to make that argument. And although the US hasn't used this argument to target hospitals itself, the US did use the dual use doctrine to target state media facilities during the war in Iraq and factories and other things that then paved the way for Syria and Russia to make the dual use argument to target hospitals. So it's an example of where, yes, completely agree with you. These are clear violations of humanitarian principles, but the problem is also the militaries using this doctrine are claiming that there has been some military use. So what's needed in addition to the WHO data confirming destruction of hospitals is a rebuttal to the claim that sort of this was being used for a military purpose.
Yeah.
All right. Are there any other questions? Joe.
Thanks. This is a great talk. Thank you. This question is primarily for Dr. Guha Sapir. I'm wondering, so I agree, I do think we should count deaths, and I think we probably do it during wars. And the example I'm thinking of is the Iraq War team from Hopkins who published the civilian death tolls in 2006. And I think the number they came up with was about 650,000. And of course, there's a confidence interval around that because they're good epidemiologists. And the question then is, how do we communicate uncertainty in these point estimates to the public, trying to, argue or emphasize the validity of the design and the study, with also acknowledging that they're imperfect estimates?
the paradox of that, right? That your
Right,
credibility
because at
depends
the
on
time, everybody thought it was super high, and they saw the pretty wide confidence interval. They thought, well, you don't know if it's 100,000 or 1,000,000, and it could be equally those. And of course, that's not at all true, but that's what they picked up on, and they said, well, you don't have any idea, so this is all invalid.
this evidence is really not very useful. How would you answer that, Doctor?
Yeah, well, it's you, as you must know, because I feel that you've read the literature. At that time, there was a huge fracas over this whole thing, as you may remember, or it is everywhere. It was all over the media, and the 650,000 was a number that was, cited and created a enormous pushback from mainly from epidemiologists of all color and creed, who came out of the woodwork to show how this, precisely what you said, how these confidence intervals were so large that this 650,000 was really not a very credible number. And so there was this whole sort of controversy, huge controversy, as you remember, that was built around, is it 650,000? Is it not? Is it a lot of people? Is it not so much people? But your question is, what do we do with these very high confidence intervals when we make a point estimate? How do we do it? Now, how should we handle this? First of all, I would say, and I know that your response is probably going to be, it's easier said than done, is that when there is such large confidence intervals, it's best not to put it out into the public, because then you're going from, it's not even 100,000, I think it was even lower than that. The lower estimate, death toll, and the highest was around 1 million. It's best not to, we've learned the hard way. Epidemiology has learned the hard way from the Iraq study. It really has learned the hard way, is that once you put out numbers, a number like that, that gets snapped up. And then it becomes really hard to take it out. So I think probably if you have very large confidence intervals, it's best not to put it out. Secondly, if you do have very large confidence intervals and you'd still want to put out your number, that's 650,000 dead, then it's best to have a narrative, a humble narrative around that number, a humble narrative that says, hey, we think it's more or less this, but it's really, we are not really sure about this, get the uncertainty out, but in a narrative that people understand. And it's not, here are the confidence interval bounds and so on and so forth, that just washes over people and they just stay. So for me, I think, first of all, if it's got very wide confidence intervals, it's most responsible to not put it out in the public arena. That's one. Second is, even if you do, then there must be a well-worded narrative that explains how uncertain you really are. I don't know whether that responded to your...
Thank you very much.
Satisfactorily, yeah.
One more question from online audience, and then I'd like to bring us to a close. There will be an opportunity to ask both of our panelists questions after the panel. And I think by email in the case of Dr. Guha-Sapir. So at least I see you indicated another question.
Yeah, and it might actually move us towards kind of a wrap up, because it was a very broad question, and I will summarize slightly. But the questioner is pointing out that every humanitarian crisis and current war and conflict is rooted in very complicated political, economic issues with multiple stakeholders, different forces that are influencing funding and decision making, and particularly in interventions of global health, even if the practitioners are holding objective goodwill to help vulnerable individuals, can independence still be kept in this space? And what is the, if we're needing to choose for vulnerable individuals here, what are the ethical spaces that we are in?
That is really a lovely question to use as our wrap up. So
So some of this question gets into some medical ethics issues that I think are more in Dr. Guha-Sapir's area of expertise. But I would just say that independence, I think, is a core sort of central, incredibly important for academic research on these contexts. And I do think that it is incredibly important to try to maintain that. Going back to the principle of dual use, I hope that sort of my criticism of the Syrian government and Russian government's bombing of hospitals will be more credible, because I've also been critical of the United States invocation of this doctrine of dual use to justify its operations in Iraq and other places. So yeah, I mean, I think this is incredibly difficult, and I think it is really difficult. I think I would say that true neutrality is not ever really possible, and we all just aspire to do the best we can.
Debbie, it's you to offer your answer to that question.
Well, you know, these are difficult, really difficult questions. The person who asked it must have some ideas of her own as to how ethical issues are resolved. Now, you know, one good example, when I was still in Sudan, in Darfur, one good live example was that the MSF hospital in El Fasher was a hospital that received sort of, you know, patients who came in, walk-in patients. And some of the people who came in were known perpetrators of violence in the village. Known perpetrators. We knew them. We knew because they were there, you know, and they were known perpetrators. And they would come in with a leg blown off or something equally, you know, devastating. So essentially, you had the two surgeons who were then the nursing assistants and things, who were trying to deal with whoever is coming in with war wounds and things. You have two people in front of you. You have two people with their legs blown off. One of them, you know, has gone in and torched the village next door last night and has, you know, I don't know what, and he needs treatment, life-saving treatment. And these guys are there. These are 27-year-old fuzzy-faced youths. That's who they are, you know. They are the young surgeons who have been sent out there. They have to make a decision at that time to say that this is a guy who's shot up a whole bunch of kids, and then the dead bodies of the children are still lying there outside. And I have to treat him to get well. I have to treat him to go walk again. And what answer is there to that question? His medical neutrality says yes. You have to treat him to get well and go out and bomb out. So they are incredibly personal decisions. And these are things that need to be resolved. And people out in the front line have to be given support by the ethicists, by the lawyers, you know, and by other medical support. They need the support, you know, today, and they needed the support 20 years ago. So that kind of support has to be given to people on the front line to deal with victims in an ethical dilemma. Yeah. I don't know whether that helped.
Well, I'm going to wrap this up in basically 1 minute. Please do look again at our précis for what we're trying to think about in this panel on the website. I think what Dr. Guha-Sapir said about humility and the need for narratives that are understandable by ordinary people who have a lot of intelligence and lived experience but don't know the technical meaning of all these terms is one of the animating principles of this Think Global series, which is like, let's understand things. So I really think that the point of our panel is to help us see what is made invisible, because so much of what enables violence is the normalization of violence, where everybody can see what's happening, but they don't see it, right? So I think what Debbie's talked about in terms of counting the what is happening here, Mara has complemented with how do we go about thinking about the what matters about the what's. So with those frameworks, the what and the how, We've had a lot to think about here. And I really appreciate everybody thinking. I can see you in the audience thinking. I can see your eyes paying real attention. And I just want to say that a recording of this event will be available on DGHI's website shortly in a few days. And I want to thank the panelists and everyone here for participating. And just to encourage us all to stay in the ethical space of that question and to really be thinking about what we see and how we make sense of it. Thank you.
It's like not even.
I thought they were, and they were, but they're not. What's the global health internet?
They. Yeah.
Oh, is it a law class?
I'll be in touch. Thank you so much.